Bismillah ar-Rahman ar-Rahim. Good evening, everyone. We will start now. Actually, this topic is very important for all orthopedic registrars and orthopedic surgeons. And its level is undergraduate, unfortunately. But we know most of registrars, they don't know how to read X-ray in bone tumors, unfortunately. This is why we prepare such talk to help registrars to guide them actually to reach a possible diagnosis from just X-ray. It is very important step in musculoskeletal oncology. طيب بسم الله نبدأ. In musculoskeletal oncology or orthopedic oncology, we utilize almost all imaging modalities, such as X-rays, plain X-ray films, CT scan, MRI, bone scan. Nowadays we use PET scan also, but always try to start with X-ray. X-ray is mandatory, even in soft tissue tumors. Even in such soft tissue tumors, we start with X-ray. What is the role of image modalities? Actually, to detect an abnormality in the skeleton, to reach a possible diagnosis, to help in staging of the disease, and to monitor the therapy, either chemotherapy or radiotherapy. Why X-ray? Because it is almost cheap, available all the time. It is a very reliable, to be honest, let us say it is a reliable predictor of histological nature of bone lesion. It is a reliable, not a very reliable. It is a reliable predictor of histological nature of bone lesion. And it is cheap, inexpensive, and informative if you could read it in systematic way. So the keyword in this slide is systematic way of reading X-ray. Remember all the time the 4M. To be systematic, remember the 4 M's to describe the X-ray in musculoskeletal tumors. Number 1, the position. That means the mailing address. The first M, mailing address, position. Number 2 is the margin. The margin. Number 3 is the matrix. And number 4 is the metastasis. So how to interpret the X-ray? The interpretation depends on the history of the patient, the age and gender of the patient. It's very important to start with the history and to relate the X-rays and other modalities to the history of the patients. Then the examination and the laboratory results. To be systematic, by the way, the key word is systematic reading. Systematic reading. So, to be systematic in analysis of X-ray, where there is a lesion, how and what. So the rest of the lecture will be about these 3 goals. To start with, wire. Is it a flat bone or long bone? And we know why. So, which anatomical bone? Is it flat or long bone? Because some lesions have a unique position in the skeleton, either flat or long bone. That means the characteristic location. such as adamantinoma, almost exclusively found in the tibia, the anterior cortex of the tibia. Chordoma is almost in the flat bone, either the sacrum or the cervical spine. It's common in the sacrum. Then the parosteal sarcoma, which is almost exclusively in the distal femur in the posterior side. So it helps. The other thing, is it intraosseous or extraosseous? And this is just anatomical description. It can help sometimes, but it's the way of description like this. This is obvious extraosseous, and this is intraosseous. Okay. Now the most important thing are the axes. These, remember, the longitudinal axis and the transverse axis. You will see the longitudinal axis in this way. Simply it is metaphysis, epiphysis or diaphysis. Is it epiphyseal, metaphyseal or diaphyseal? That's it. Okay. You see this, you will find this photo or this diagram almost in every orthopedic textbook. Every orthopedic or any orthopedic textbook. It is very important for us. Very important for us. Remember this. Epiphyseal almost exclusively for chondroblastoma and GCT. Then metaphysis, the metaphysis is almost for the rest of the tumors except the cortical one. And few exceptions in the diaphysis. Okay, in the diaphysis. So examples for the epiphysis, the epiphyseal, as I said, the striking example is chondroblastoma. It's chondroblastoma. Okay, this is a common MCQ by the way. Then the GCT, which is epiphyseal with, it is metaphyseal with epiphyseal extension because it starts almost in the metaphysis, not in the epiphysis, but it will extend to the metaphysis. So it is metaphyseal with epiphyseal extension. How to read in the transverse axis? This way, either central, eccentric, concentric, eccentric, cortical, and so on. Like this. This is central, like this one. Eccentric, cortical, peri or parosteal, and intraarticular. Okay. So the central or the concentric regions lie in chondroma. The eccentric, like non-ossifying fibroма, IBC, chondromyxoid fibroма, these are eccentric, one side of the bone. The cortical lesion as steatocytoma, and sometimes small non-ossifying fibroma. Small non-ossifying fibroma is cortical. The parosteal or perosteal, the striking example is osteochondroma, and as its name implies, parosteal osteosarcoma. Okay, this is via the first method. Then we go for how. You know here the site or the location. Now we goes for how, the description of morphology. Okay, so to start with, is it multiple or solitary? Is it a single lesion or more than one lesion? Simply like that. Okay. Multiple lesions actually found in both benign or malignant. Benign lesion or malignant lesion. Benign lesions has multiple hereditary exostosis and polycytic fibrous dysplasia. Okay. In malignancy, the strong example is metastatic lesion, metastatic disease, I mean, multiple myeloma, and bone tumors, other bone tumors, as lymphoma, leukemia, etc. Sometimes Ewing sarcoma and osteosarcoma also found to be multiple, what is known as synchronous or metachronous. Metachronous osteosarcoma. This is multiple myeloma. Okay. Now, the most important thing is the pattern of bone destruction. Pattern of bone destruction. This actually reflects the direct effect of tumor cells and response of the tumor by osteoclasts. Activation actually of osteoclasts.
Macchina me? Wait.
Sorry? Someone's talking. Please,
How
who's
about that?
talking?
Not yet.
Please mute. Mute your mic, please. Okay? Then cortical bone destruction is less rapid than the cancellous bone. This is known for us because you need 70% of cancellous bone to be resolved to appear in the X-ray. Okay? So the cortical bone destruction is less rapid than cancellous bone, although it appears early in radiography because of its high homogeneous density. The cancellous bone, as I said, large amount of bone destruction needed, almost 70% loss of the minimum content to be seen in the radiograph. Okay? Now, what is the most important is what is known as Ludwig's classification. Ludwig's classification. It is not important for you to know this classification. I mean the nomenclature, Ludwig's, but you must know these types. The geographic, the moth eaten, and the permeable. And you know the difference in a minute. Because it implies the aggressiveness of the tumor. Okay? The more aggressive the tumor, to be far away from the right one, and vice versa. Aggressive and not malignant, huh? Aggressive tumor, aggressive. Okay. Type 1, which is geographic, it is uniformly destroyed area, usually with sharp defined border. The other name is narrow zone of transition. يعني زي المرسوم بقلم الرصاص. يعني بقدر احددها. Okay. This what is known as geographic. Geographic. Okay. There is an obvious margin with sclerotic rim. This indicates what? Indicate slow growing tumor that giving time to the bone to react to it. Okay, the tumor try to eat the bone minerals and the bone structure, I mean. But as it is a slow grower, the bone will reflect and react to this tumor, try to isolate it by forming this sclerotic ring around it. Okay? So, most of the time, there is benign lesions. Benign lesions. As unicameral bone cyst, incontinence, early stages of GCP, non-ossifying fibroma. Okay, these are all geographic type of lesion. Geographic type of lesion. The other one, type 2, is moth-eaten. Moth-eaten. And this is with multiple small various sizes and often cluster lytic areas. طيب المحيطا والبرمياتيف اللي هو تايب 3 بيشابهوا. الفرق الوحيد حاجه صراحه descriptive was the size of the hole or the lytic area. The size. If it is more than 1 millimeter, this is moth-eaten. Okay, this is moth-eaten. If less, this is permeable. It implies fast growth. Most of the time, it is due to malignant condition. Okay, like multiple myeloma, lymphoma, metastasis, and sometimes during lymphoma. Okay. The third type is the permeative. Also, multiple tiny lucent areas is usually less than 1 millimeter in diameter. This is the difference. Less than 1 millimeter, and the moth-eaten type 2 is more than 1 millimeter. And as you can say, it is just descriptive. Okay, and so it is very hard actually to differentiate between the two. Honestly, in the X-ray, it is very hard because sometimes you find both in the same bone. You find both permeative and moth-eaten. So it is just descriptive, but it implies a very important issue, which is fast growing healing. Fast growing healing. Again, the examples are the same: lymphoma, leukemia, Ewing sarcoma, multiple myeloma, and infection. By the way, infection. Infection as osteomyelitis can give both permeative and moth-eaten type of bone structure. As I said earlier, the distinction between type 2 and type 3 is not easy to find, and sometimes they coexist. الاثنين كلهم في نفس الجملة. Okay. And this is the important thing. As you go from this side to this side, it goes more underground. Starting from benign to malignant. This is important. Now we go to the other thing, which is the border and the margin. In other way, we have just seen what the lesion did for the bone. But this is a pattern of bone destruction. Now we will see what is the bone doing in response to this lesion. This is the border and the margin. That's it. Okay. Again, Ludwig's classify this in 3 types. It's not very important to know the name, but what we want you to know is sclerotic horizon. This is hazy, and this is ill-defined. Okay. So type 1 is sharp demarcation with sclerosis. This one. B is sharp demarcation but without sclerosis. Why? Because here the bone has time to isolate the tumor. Here have less time to isolate the tumor, and here it is ill-defined region between the lesion and the host area. You cannot know where is the border between the normal bone and the lesion. This is what we call wide zone of transition, and this implies malignancy. Okay? So this is the most likely A, most likely is benign, and this most likely malignant. Okay. Yes, as I said, the more well-defined margin, it is slower and most likely benign, and the vice versa. This is just examples in camera bronchs. A, in camera bronchs, non-ossified lymphoma, osteoblastoma. B, X, ECT, plasmacytoma. The B, multiple myeloma. C, acute smolitis, metastasis, sarcoma, and sarcoma. Now, this is sclerotic margin. For the birth, it is a bit hazy without sclerosis, but sclerotic ring around the tumor. That implies the tumor and in the bone have no time to isolate the tumor like this one. Right? This is this area, the intensity. Now we'll see the cortical response. We start from the center. We see what the tumor did to the bone and how the bone react to the tumor. This is in the center. Then we go a step further to see what is a cortical response. Okay? We start either with industrial scalloping, like this one. This is common. Remember this name, industrial scalloping, common in incondrama. And is one of the radiological signs of malignant transformation in control. Okay? If I found in industrial scalloping like this in chondroma, I would suspect malignant transformation into chondrosarcoma. Okay. So industrial scalloping will be found in long-standing benign tumor in chondroma and early stage of chondrosarcoma, type 1, histologically type 1 or grade 1 chondrosarcoma. Okay. In him, this is what we call industrial scalloping. Okay. The other thing is ballooning. Ballooning. This is ballooning. Okay. In more aggressive lesions, outer cortex may be too thin to be seen on a plain film X-rays, and only be evident in other modalities, MRI or CT. This line GCT, and aneurysmal bone 6. Again, it is. This is what we call ballooning. Okay. The other thing may be the reverse. Will be not thinning, will be sclerosing like this. And this is steroid osteoma. This is the nidus, very tiny, and we react with very sclerotic around it, no? Thickening of the cortex or sclerosis. Yes. So this is industrial sclerosis to be obvious on one side, here, and balloon on the other. The other thing is cortical destruction. And this is common in malignant, what we call breach of the cortex or cortical breaking. You know? Cortical breaking or breach of the cortex. Okay. After the cortex, there is periosseous reaction. Now we are in the cortex. The other step is periosteum and soft tissue around it. Okay. We will see this in a minute. Let us first talk about the mineralization of the matrix of the tumor. All tumors, almost all tumors are of three origins, either chondrite, osseous, or fibrous. From the X-ray, I can judge. And I have a clue about this tumor. If you remember in the first or the second slide, I said it is reliable in giving or in coincides with histological diagnosis. If you remember, this is here. From the matrix, I can judge what type of tumor. What type of tumor? Okay. Is it chondroid? Is it osseous or fibrous? The chondroid tumor give what we call or known as popcorn appearance. Popcorn appearance. In other foods, you can find a C-shape or a cone-shaped tumors, but with almost inherited spots you find known as popcorn-like or popcorn appearance. This because of the calcification of the tumor. This because of the calcification of the tumor. And by the way, sometimes you will not find this popcorn appearance in a chondroid lesion, especially grade 1. You will not find this popcorn-like appearance. That means the calcification is not happening yet. Simple like that. Simple like that. So this popcorn appearance is due to calcification of the tumor, the chondroid lesion. That's it. The striking examples are inchondroma or chondroma. The osseous lesion or the osteoid lesion will give what is known as cotton or fluffy or cloud-like appearance, like this one, cotton or fluffy appearance. Okay, and this almost all the time suggest osteocyte. Now, the fibrous lesion will give what is known as ground glass appearance. Ground glass appearance. And this is because of leather woven bone. Woven bone, not woven bone. Give the ground glass appearance. Or other word, the purple soap appearance. Okay. The ground glass appearance اللي هو نعمل كمان الناس اللي مش يورو في بداية الشتاء البحيرات اللي بتتجمد تكون في الطبقة اللي فوق تكون خلاص فيه جليد لكن تحت لسه الموية موجودة الشكل هذا بيكون what is known as ground glass appearance. ولو انتوا تشوفوها أيضا ربنا يفتح عليكم تمشوا أوروبا أو تحطوا لكم موية في الفريزر لسه ما جمد كويس خلوها على شوية تلاقي لما يكون جمد كويس ده ground glass appearance. or bubble soap appearance اللي هو اللعبة اللي كنا بنلعبها زمان دي مية الصابون ونحط فيها الخرطوش ولما تنفخها في الهواء انفخ في العلبة دي فهي العلبة تطلع. This is bubble soap appearance. And the striking example is fibrous dysplasia. Fibrous dysplasia. Ground glass or bubble soap appearance. أي كتاب تلقاه كده يجيبهم في الانسكيوز ويجيبهم في الساس. يكتب طوال جراوند جلاس ابيرنس او لو جاب لك حاجه جراوند جلاس ابيرنس هي فايبرس خلينا نقول فايبر نتفق على انها 100% this is fibrous لكن most of the time it will be fibrous dysplasia. So, examples this is يا ريت كان في تفاعل يعني كان نسمعكم لكن this is popcorn classification popcorn. So this is chondroid. This is chondroid. This is velvety or fluffy or cottonoid, which is steroid lesion. Okay? Steroid lesion. Most likely this is osteocyte. And this is the pupil sore or round glass appearance, which is fibrous lesion. Okay, now we go back to the peri-osteal reaction and soft tissue extension. يلا تذكروا نحن بدينا from the center. What is the lesion doing to the tumor? I mean the tumor doing to the bone and the response of the bone to the tumor. Then we go to the cortex and now the peri-osteal reaction and soft tissue extension. The peri-osteal reaction either continuous or interrupted. Continuous or interrupted. Okay, and this implies is it aggressive tumor or fast growing or slow growing. Okay, the continuous lesion, that means the lesion, the continuous peri-osteal reaction, that means the tumor is slow growing tumor. So most likely it is a benign lesion. Okay? And vice versa. If it is discontinuous, it implies this is most likely malignant lesion. Rapidly growing lesion. Okay? طيب معظم البيريوستال رياكشن بيشوفون يا شباب كلامنا كلام ثم يتعرفوا معظم اللي بيشوفوهم هم يتعرفوا. Okay? If it is continuous, most likely it will solid blood. يعني الستيرز اللي شفناه قبل دي تبدا بيريوستي and immediately oh, سامعين؟ الو
السلام عليكم يا مستر. الصوت رجع لكن الشير اختفى.
طيب هاي الشبكة بس انتربتد.
ايوه
طيب نحاول تاني. قلنا this is a continuous it is due to lay down of newborn and this is a storage joint and the peroxide. Okay. This is another example. Continuous or interrupted. There is single lamella or multiple lamella. Okay. Early stages of infection, acute infection, will give lamella fracture, lamella process reaction. Okay. Now the common are the interrupted or discontinuous, which could be either sunburst, common in osteosarcoma, onion peeling or onion skinning, which is common, or the striking example is Ewing sarcoma, and the Goodman triangle in late osteomyelitis and osteosarcoma. Okay, so this is a solid patronage, continuous in lamella, and this is interrupted perpendicular, which is sunburst SSI, and this is multi-layered onion peeling, which is common in Ewing sarcoma, and this is Goodman triangle, which is common in infection and osteosarcoma. Okay. After we revise all these, so we want just to know, is it what? What? We want to know only to answer one question. Is it a benign or malignant? So we should combine these findings of X-ray reading, tube, history, and examination. Please, history and examination, and other yes, okay, to reach the possible diagnosis. Okay. Now to sum up, we should read the X-ray one. Either the tibia, femur, the longitudinal axis, is it diaphyseal, metaphyseal, or epiphyseal? Then horizontal, is it central, eccentric, cortical, or extra osseous? Then is it solitary or multiple? And you see the margin of the tumor. Okay. Then the matrix of the tumor and the cortex. Then the periosteum and soft tissue. This is what is known as systematic reading of X-ray. If you follow this diagram, you will not miss anything. This is how to be systematic. Which one? The longitudinal axis, the horizontal axis, the multiple, the number of the regions, is it multiple or solitary, the margin, and the matrix, the cortex. Cortex, is it scalloped? There is ballooning, thickening, thinning, or is it breach? This is what is in the cortical situation. Then the periosteum and soft tissue. كده انت يكون لا تغطي شاردة ولا واردة في هذا الموضوع. This is the systematic way of reading X-ray in bone tumors. السلايد دي يا شباب في أبلي أي زول يمشي يفتح أبلي كويس. section 1 the oncology chapter institute oncology chapter تلقى الحاجة دي في أول صفحتين. بس أنت أزعل نفسك الأسئلة دي لما تيجي تقرا الإكس-راي بس ببساطة لخص المحاضرة دي كلها. Is the lesion solitary or multiple? What type of bone is there? Where is the lesion in the bone? Are the margins of the lesion well or ill defined? Are there flags of classification of the lesion in the matrix? Is the cortex eroded or destroyed? Is there any terrestrial new bone formation? And does the tumor extend into the soft tissues? Just when you elevate an X-ray to read it, just remember these questions in this manner. Okay. Okay. So to sum up and to take home message is first you should have an eagle eye. Please you should have an eagle eye. لأن كتير أنت بترفع الإكس راي بتقول ما في حاجة. Please related to the complaint of the patient. Complaint of the patient. The age of the patient. In other words, the history of the patient. لما ترفع إكس راي تحطها في الجرين بوكس ما تقول ما في حاجة. Simple analysis. right? Most of the time يكون ما في حاجة. Okay, I agree. لكن الكلام اللي بتقوله بيتفق بعدين تكون راجعت الهيستوري بتاع العيان تمام شفت الايدج الكومبلكس عملت الاكزامينيشن بالذات التارجت الايدج بعد ذاك ترفع الاكس راي شوف meticulously with an eagle eye. With an eagle eye. تفحص تفحص. تمام. This is number one. You should have an eagle eye. Number two, be systematic. احنا اللي الليكشر دي كلها بس how to be systematic. How to be systematic. Number three, try to see and describe what is the lesion going to the bone and what is the bone going to the kidney. لو طلعت الثلاثة حاجات، ذكرت الثلاث حاجات دي إن شاء الله أنت ما تجيب عملية ولا العيان يجيب بإذن الله. تمام؟ That's it. ربنا يوفقكم. لو في أي سؤال الساعة 2 10. أوكي، لو في زول عنده أي سؤال ممكن. العنوان الليكشر دي هتنزل لكم إن شاء الله. لو في زول عنده أي سؤال، أنا الزمن ضيق مصر حالي عنده ارتباط تاني على البرنامج، فأنا قاعد أهو في مساعدة في الجروب وبقول لكم عليه إن شاء الله. تمام. تسلموا يا شباب.